Good afternoon, everyone, and welcome to our final day of the Women's Health Summit. Thank you to the 92nd Street Y for organizing this incredible and informative event, and to the Katz Institute for Women's Health and Nancy and Larry Roth for their continued support in providing our community the information they need to advocate for the care they deserve. I am Dr. Michael Nimaroff, Senior Vice President and Executive Director of OBGYN at Northwell Health, and the Chairman of the Department of OBGYN at North Shore University Hospital and Long Island Jewish Medical Center. We would be remiss in hosting a Women's Health Summit if we didn't talk about the life stages across the continuum of a woman's life. For many women, obstetricians and gynecologists serve as their primary care provider, and their main connection to medical care is through their annual Pap smears or prenatal care. It is important for women to stay well and up to date on health screenings with their annual Well Woman visit. This is also a good time to speak with your doctor about any health questions or concerns you may have. Today, we'll be addressing a number of OBGYN topics covering the ages and stages of womanhood. Dr. Gunter, author of the Vagina Bible and the Menopause Manifesto, will kick us off. After that, you'll be invited to join one of 3 breakouts covering important women's health issues. Northwell experts will speak to motherhood and fertility, menopause, and pelvic health. We'll come back together to end the day with a conversation about the importance to raise awareness of women's health. And one way we are doing this is by storytelling through the Misdiagnosed documentary. Have a great day.
Hello. Hi, I'm Dr. Gyn Gunter, and I want to thank the 92nd Street Y for inviting me to speak at their Women's Health Summit. I am an OBGYN. I'm author of the new book, the Menopause Manifesto, and I'm also the author of the Vagina Bible, which you can see got a bunch of translations listed up here. It's been translated or going to be translated into 19 languages, which is super cool. Just some housekeeping notes before I get started. I have a large dog who I'm hoping will stay asleep, and I have a one-eyed cat who doesn't see well, and you might hear her running around the house. And often the time she most wants to sit on my lap is when I'm doing something by video. So just some housekeeping. What I'm going to do is tell you a little bit about my book, why I wrote it, what was sort of the impetus behind it, and what I hope to give you. In addition, I'm going to do some reading, and I'm also going to do a little bit of sort of show and tell, because I have a couple of cool things that I also want to show you. Maybe you can tell from my shelves that I'm a little bit of a collector. This is a box someone gave me, which is a lunchbox about syphilis. I'm not sure who would carry that, but it's super cool. And I have a lot of little things like that. So why the Menopause Manifesto? Well, when I was on book tour for the Vagina Bible, everybody wanted to talk about menopause. I mean, they wanted to talk about the vagina and the vulva and sex as well, but they wanted to talk about menopause. And, you know, as an OBGYN, you know, I know all of these things, and it's hard to know outside of your own practice, you know, really, you know, what's going on maybe culturally. And what I heard over and over and over again was that women felt lonely in menopause. They felt they had no culture, and they felt they were struggling to get information, that it was literally an act of feminism to find out what is happening to their body. And, you know, I've been in medicine since I was pretty young. I was 20 when I started medical school. So I've had high quality knowledge about my body for, you know, most of my life and the majority of my reproductive life. And I started to think that, you know, everybody needs to have that information. You know, most people have the basics about puberty, even just measuring, you know, your kid along the, you know, the door jamb with a pencil is an acknowledgement that puberty exists. But people know almost nothing about menopause, and there's a lot of confusing information online. Even the way journalists cover it is often biased. For example, we hear about all of the very rare risks for treatment for menopause, really rare risks, but we don't really hear so much about the rare risks of medications for erectile dysfunction. Interesting that, isn't it? And so, there's not only this difficulty getting information to people, but the way we view menopause has been so affected by our patriarchal culture that I wanted to take not just medical information and give it to women and to everybody really, but to also explain some of the culture behind menopause and the history of menopause, why we have it. We have it for a reason. And also, give people the tools so they can navigate the information they find online, so they can question their medical providers, and they can separate the fact from the fiction. And so that is the Menopause Manifesto. So some of the research, I did some cool research for this. I'm not on the standard medical research, and obviously I knew a lot of it, but I spent time really trying to get some of the history of menopause. And I'm kind of obsessed with the idea about starting a menopause museum. And I've started a little collection of things. And I'm going to show you sort of a little show and tell along the way of some of the things. But one of the first things I want to show you before I read from my book is I ordered a whole bunch, during the pandemic, there was a lot of time for ordering of books, old textbooks on menopause, because I really wanted to read the original words of people who were first writing on it. And this is actually, Edward Tilt's book. He's a physician from the 1800s, and he actually wrote the first sort of respected book in English on menopause. And it was just really so fascinating to see the words and to hear how menopause was described by Tilt. And actually, obviously a lot of the language is patriarchal and a lot of it is dismissive, but for the day, he was actually pretty advanced. And so before I read from my book, I want to read you a paragraph from Edward Tilt's book from the 1800s. So this is about just menopause in general. Besides this vast improvement in health, it must not be thought that the change of life implies the loss of all personal attractions. There is a beauty about childhood that seldom makes a vain appeal for fostering care. The beauty of youth fascinates. That of mature age excites admiration. But in many women, there is for long after the change of life an autumnal majesty so blended with amiability that it charms all who approach within its magic circle. To those fired with ambition, it may be safely said that the home government of society, from the highest to the lowest of our social strata, offers a wide field of employment to women after this period of life. Many never think of cultivating their minds until they find their influence faded with their charms, and then set about acquiring a less perishable empire and employ this period of freedom in literary pursuits. So, obviously there's some negative language in there, but it's just really fascinating to read the words of the people who were trying to help women in menopause before they even knew hormones existed. But I like that autumnal majesty. So although, I'm not so happy about, many don't think about cultivating their minds. But anyway, so this is Edward Tilt's book. And this is actually one of the books in my collection that I love the most. Okay. Ooh, got a little bit close there. Okay. So Menopause Manifesto. So I'm going to read you a little bit from the introduction. The manifesto. If menopause were on Yelp, it would have 1 star. This establishment has temperature control issues. Drenching heat followed by terrible chills. Defies the laws of thermodynamics. Would not recommend. Awful, awful, awful. Bleeding was scheduled but was rebooked without notification, so arrived 3 weeks later than expected while I was in an Uber and I flooded the car. The driver gave me a terrible review. The sex was dry. And it's no surprise. Most women have no idea what to expect when they are no longer expecting a period. And it's uniquely awful and disempowering to not understand what is happening to your body and why. Menopause is like being sent on a canoe trip with no guidebook and only a vague idea where you're headed, although the expectation is it's awful. There will be no advice on how to get there or how to manage any of the obstacles, such as rapids. That is, if any exist. Who knows? Have fun. Have fun figuring it out. Good times. Oh, and don't write. No one wants to hear about your journey or what it's like when you arrive. Fear? Check. Uncertainty? Check. Medical irrelevance? Check. Unpleasant symptoms? Check. No wonder menopause receives such awful reviews. The culture of silence about menopause in our patriarchal society is something to behold. Menopause doesn't even rate the shame that society gives to the vulva and vagina. Apparently, there is nothing of lower value than an aging woman's body. And many in our society treat menopause not as a phase of life, but rather as a phase of death, sort of a pre-death. What little that is spoken about menopause is often viewed through the lens of ovarian failure. The assertion that menopause is a disease that exists because women and their ovaries are weak. The only grounds for this claim are that men don't experience menopause. But comparing women and men in this way is the same as comparing the liver with the heart. The liver isn't weak or diseased because it doesn't beat like the heart, and women aren't diseased because the ovaries stop making estrogen. The absence of menopause from our discourse leaves women uninformed, which can be disempowering, frightening, and makes it difficult to self-advocate. Consequently, many suffer with symptoms or don't receive important health screenings or therapies because they've been dismissed with platitudes like, this is just part of being a woman, or it's not that bad. But the issues with menopause even go beyond these knowledge gaps and the medical neglect. Women tell me that menopause is lonely, and there are no stories or culture. And so there is no whisper network to take up the slack from medicine, nothing to offer comfort. Okay, now I want to fast forward to talking a little bit about the menopause transition, which sometimes is called premenopause or perimenopause. And that's the time kind of leading up to the final period. And it's a time of hormonal chaos. And some people have their worst symptoms during this time because some months you can have very high levels of estrogen and other months very low levels. And also people forget about this. In addition to your estrogen going up and down, some of the hormones in your brain are doing the same thing. And interesting, as you'll find out in the book, some of the drivers of the symptoms of menopause aren't estrogen. They're actually the changes in hormones in the brain. Fascinating, right? Okay. The hormone fluctuations that start in the menopause transition can trigger a variety of symptoms. For some women, these may be bothersome enough to treat. For others, having the knowledge that what's happening is typical may be enough. Thinking a weird body thing is uniquely yours is very disempowering, and many women are relieved simply to know their experiences are common and expected. It's also important women know what symptoms might be a sign of a more serious concern and what's annoying but not dangerous. For example, I was headed to Europe 8 months from my last period, and as I'd had some significant hot flushes, I was sure I was done. I was stoked not packing pads and tampons. Then 5 minutes into the 10-hour flight, the seatbelt was still on. The seatbelt light was still on. Bam! I felt a gush of blood, and my underwear was soaked. I felt like Michael Corleone from The Godfather 3, sitting on the airplane toilet seat, muttering to my ovaries. Just when I thought I was out, they pull me back in. Changing underwear in an airplane bathroom, just another space not designed for menstruation, and using cheap airplane menstrual pads for 10 hours that resulted in an irritating vulvar rash at the start of my vacation was very bothersome. The amount of blood was not. Had I been embarking on a lot of international travel, I might have considered medication to help regulate my periods because menstrual hijinks at cruising altitude are not my jam. That's why it's important for women to know all their options so they can choose if they want treatment or not. Quality of life concerns aren't trite. It's medicine. Okay. Now, I want to fast forward to some of the treatments. And this is, again, part of my fascination with the sort of the history of menopause so people know where we are. And there's this sort of common idea or discourse that Ancient therapies were all good, and they certainly weren't, and you'll read a lot about awful ones in here. And there's also this lie that that before pharmaceutical hormones that we know today came along, hormones were sort of made by these, I don't know, like mom and pop shops who were grinding, I don't know, ovaries in their backyard, which isn't true. So actually, before hormones were available, there were a lot of people who offered a lot of treatments for menopause, and many were actually dangerous. So I want to talk about one specific one, which is sort of uniquely American, also because I have one. Where is it? Oh, on this side, I have one of the bottles of it. It's amazing what you can find on Etsy. Again, this is from the 1800s. Okay. Supplements as the new patent medicines or medications. Medicines. Supplements as the new patent medicines. Proprietary elixirs and concoctions have been around for a long time. They were originally called nostrum remedium, our remedy in Latin, eventually becoming known as nostrums. The term patent medicine comes from products that found favor with royalty and were subsequently issued a royal letter or patent as endorsement. They were heavily advertised with wild claims and patient testimonials, exactly like many supplements today. Patent medications were popular in the 1800s. It's understandable why women approaching menopause turned to them, as many medical therapies were crude and ineffective at best. Common prescriptions were bloodletting, leeches to the vulva, purgatives, sudorifics, stuff to make you sweat, sedatives, belladonna, and vaginal injections with a solution of acetate of lead. Even removing the ovaries was recommended, even though mortality from the surgery was high. Advertisements for patent medicines were aimed specifically at women. The same product was typically recommended for almost every medical condition, from uterine prolapse to infertility to missed periods, often code for pregnancy, and hence the insinuation the product could induce an abortion, and to menopause. Some contained pennyroyal, an extract from an herb in the mint family that has long been used as an abortifacient. It's highly toxic and should not be taken in any form or dose. While it may induce uterine contractions, side effects are liver failure and death. Other common ingredients in these elixirs were quinine, boric acid, and oil of theobroma, which you might know as cocoa butter. Yes, some patent medicines contain chocolate. One of the most successful patent medicines was Lydia Pinkham's vegetable compound for ailments peculiar to women. As an aside, that sounds like a good name for like a Netflix series. And it was specifically geared towards the change of life or menopause. According to Rainey Horowitz, who took a deep dive into Lydia Pinkham and her vegetable compound for the Embryo Project Encyclopedia, it's well worth a read. Lydia Estes Pinkham invented this concoction of alcohol, roots, and herbs in her kitchen in 1873 in Lynn, Massachusetts. Pinkham started small, but as requests increased, her business expanded. The product was heavily advertised as a woman's cure for women's ills. It could apparently do all of the following: give quick relief and effect a permanent cure in all cases of irregularity, faintness, headache, chlorosis, megrims, displacements, periodic bearing down pains, dizziness, palpitations, depression, pain in the back, and those dull and listless days when you feel fit for nothing. Chlorosis is anemia or low blood count. Megrims is low spirits. Displacements is prolapse. And bearing down pains, I suspect, is menstrual cramps. This was gynecology in a bottle. And yes, if something sounds so good to be true, sounds too good to be true, it is. We know that all these conditions are caused by vastly different biological processes, and there isn't one therapy to rule them all. Each bottle came with an 80-page free book on women's health entitled Lydia E. Pinkham's Private Textbook Upon Ailments Peculiar to Women. Women were even encouraged to send in questions to be answered by Pinkham, and they received handwritten replies, even for years after her death. That became a minor scandal, with the Pinkham brand claiming no one ever suggested Pinkham herself wrote all the replies. Pinkham's original recipe included black cohosh, life root, unicorn root, pleurisy root, and fenugreek seed. The black cohosh was apparently the ingredient for menopausal symptoms. The original recipe contained alcohol, though this wasn't disclosed for many years. Pinkham's vegetable compound was tested in 1911, and the results published in the British Medical Journal. It was 19.3% alcohol, which is the same alcohol content of most port wine, for reference. I know, right? No evidence of any active substances was identified. While it's possible the testing of the day may not have been capable of detecting an active ingredient, that's being generous to Pinkham on my part, given the recipe and Pinkham's method of extraction, it's very likely there was no active ingredient except the alcohol. I decided to perform a trial of a home version of Pinkham's tonic, well, the alcohol part. I wanted to see if 30 milliliters, 1 tablespoon, of 19.3% alcohol every 4 hours, the dose of the supposedly inactive ingredient in Pinkham's vegetable compound, might improve a dull and listless day when I felt fit for nothing. I chose a good quality port with a 19.5% alcohol content. Look, I wasn't going to drink nasty port before my coffee. Between the COVID-19 pandemic and the smoke-filled skies of California's fire season, it wasn't hard to find a day when I felt fit for nothing. So, one Sunday morning, I began with a shot of port after brushing my teeth and continued to dose myself regularly until bedtime. For science. Let's just say it smoothed the day a little. And no, I am not recommending it as therapy. Clearly, there was an active ingredient, just not quite as advertised. And here is a bottle. It's part of our show and tell from Lydia Pinkham's. See, I don't know if you can read the writing. Lydia Pinkham's vegetable compound. Again, it's amazing what you can find on Etsy. Really, really heavy bottle. Yeah, it's like a flask. Okay. Oh, that's sitting next to, I forgot about that. That's an incontinence ring. They're super cool. You put them in the vagina and they support the urethra. They're really actually very good for what's called stress incontinence. They act like a backstop. Anyway, that's probably for another talk. Okay. So I'm going to now skip ahead to the end of the book. I'm going to leave you with my final thoughts on menopause. Oh, before I get to my final thoughts, I want to talk a little bit about something that I cover in detail in the book on why we have menopause. It's actually an evolutionary adaptation. So everything that happens with our body has evolved, right? There's no accidents. Things that, we evolved to have periods so we can reproduce. We have heavy periods because human pregnancy requires all that blood, okay? We also have heavy periods because pregnancy is such a biological toll that making the embryo work through it, getting through a really thick uterine lining, helps to ensure that you get the highest quality embryo, right? And so people are like, well, why do we have menopause? Well, if you look at our closest ancestors, the chimps, they have very similar ovarian function to us, but they don't go through menopause. They just die. In fact, most animals die when their ovaries stop functioning. They live to reproduce and they die. And we don't. We keep living. And so the question isn't why do our ovaries stop working? The question is, how did we get strong enough to live beyond our ovarian function? It's more of a superhero story than anything else. And it turns out that we started to live beyond our ovaries. The hypothesis is called the grandmother hypothesis. And it's the idea, or it's the hypothesis, that there was worth in menopause. So if you look at our ancestors, having a baby has a huge biological toll. There is blood loss, there's tissue trauma. You may not be able to collect food or get shelter on your own for some time. And you're caring for a uniquely vulnerable infant, right? There's no, drop and go situation in human pregnancy. You have an infant who is completely dependent on you, completely. And the reason for that is that's how we evolved, and getting a big head through a small pelvis, the kind of pelvis we need to walk upright, requires that there's going to be carnage. And so, our advanced neurological system takes time to develop after birth. And so you have someone who's just delivered, who has to pay a lot of attention to a very vulnerable infant who may also herself be, unwell and recovering, and who can help gather food and shelter and provide care for the other children if they exist, is a grandmother. But she can only be helpful if she's not burdened with those tasks, reproduction herself. And so the grandmother hypothesis suggests that some ancestral grandmothers lived a few years beyond their ovarian function, and they would have been successful in helping their family reproduce, sort of genetics the long game. And so they would have passed those genes for longevity past menopause along. And so that eventually led us to having this, fairly long post-reproductive phase. The last couple hundred years have then given us more years beyond that. But this old theory that all women just drop dead before menopause is not true. There's lots of, it's true that the average age that we live has extended, and it is also true that many women did die in childbirth. But if all women died before the age of 50, we wouldn't have evolved to this point. There would have been, too many children left parentless, and too many disrupted families. And so the idea, the grandmother hypothesis, suggests that grandmothers had great value to their family unit and probably to the culture in general. And that's kind of a different story, isn't it? And there is one other group of mammals that has menopause, and that's killer whales. And we see the same pattern as we do with our sort of ancestral grandmothers, that killer whales that have, when there's a grandmother, their grand calves are more likely to survive. They may share food in times when food is scarce. And it's also really interesting with killer whales. Male killer whales die around 50, so they don't actually have any use post-reproduction. I didn't really look into that because, men are like really my concern. The longevity of men anyway. And so it's just fascinating to me that we see the same pattern in killer whales that we see in humans. And, they also, have live in, tightly knit collectives, like humans used to. And so menopause looks like it has evolutionary value. It's a different spin on it, isn't it? Okay, so I'm going to end here. Okay. Many women have been conditioned to fear menopause as an expiration date for relevance and as a sign of weakness only because that is what men thought. In fact, we have this amazing data that tells us that menopause is the opposite, a time when historically women contributed great things to society because of their knowledge and their age. Yes, menopause has symptoms and is associated with medical concerns, but there is help, and it's certainly not a premorbid state. When told by a patriarchal society, the story of menopause is one about deserted youth, frailty, and diminished worth. When told by a patriarchal society, the story of menopause is one about deserted youth, frailty, and diminished worth. The story I want you to remember is about value, agency, and voice, and the knowledge to keep yourself in the best of health while demanding an equal seat at the table. That's my manifesto. And so in this book, you will learn about the history of menopause. You will learn why we have it. You'll learn about all the medical conditions associated with menopause, because it is true, it does trigger a lot of medical conditions. You'll learn about the symptoms, and you'll learn about the treatments. And I want to end with one more cool show and tell. I have to find where I put it on my shelf. Oh, it's right behind me. So there's a lot of talk online about so-called natural treatments, and I mentioned earlier that one of the talking points is that hormones before big pharma were some kind of like mom and pop things made by women with special healing powers, and actually they weren't. They were injections of things extracted from hog ovaries or amniotic fluid. And this is something that I found. You probably can't really see it, but let me see if I can show it to you. Oh, it's probably not going to focus on it. But this is a vial of something called theolin, which is a very, very old hormone therapy from the 1920s and 1930s. And it's probably an extract of hog ovary, and it's in oil, and it was an injection. And it's made by Park Davis, a pharmaceutical company. And these kinds of therapies probably help some women because there's definitely estrogen in it, but they probably produce really wild swings in hormones with super high levels and super low levels. And, we're probably certainly better than vaginal injections of lead, which we discussed, but not as good as what we have today, which is incredibly refined. And I also want to end with the safest way for people who are interested in taking hormone replacement therapy, menopausal hormone therapy, is a transdermal route. And there are many excellent sources, pharmaceutical sources for that. And I would caution people, and there's a lot of information about this in the Menopause Manifesto, caution you about compounded hormones because those are untested. Compounding estrogen is actually very difficult, and there's a lot of safety concerns with those products. And with modern pharmaceuticals, you can have everything customized to your needs with a modern pharmaceutical. There are also lots of non-hormonal treatments for symptoms of menopause. And so really what I'd like people to know is to have the information so they know about all the wealth of treatments out there, and they can choose the one that works best for them. That's empowerment. So thank you again so much to the 92nd Street Y for having me. Thank you for listening, and just keep on with the manifesto, and remember that menopause is not a sign of weakness. It is a demonstration of strength. Bye.
Hello, I'm Dr. Christine Metz, a researcher at the Feinstein Institutes and a member of the Katz Institute for Women's Health at Northwell. I co-direct the ROSE study with Dr. Peter Gregerson. ROSE stands for Research Outsmarts Endometriosis. The ROSE study includes a team of nurses, coordinators, clinical collaborators, scientists, graduate students, and research participants. Our goal is to better understand endometriosis and to develop improved diagnostics and treatments for patients suffering with this condition. So what is endometriosis? Endometriosis, or endo as we call it, is defined as the growth of endometrial-like tissues outside of the uterus. This means that cells normally found lining the inside of the uterus, or endometrium, which is shed each month, grow outside of the uterus as lesions. Endolesions are typically found in the abdominal cavity around the ovaries, uterus, bladder, or rectum. Each month, in response to female hormones, these lesions can bleed, causing pain, fibrosis, and inflammation. Repeated cycles can lead to debilitating damage. There are many misunderstandings about endometriosis, so let's review. True or false? Endometriosis is simply characterized by severe period pain. False. Endometriosis is a complex condition with many symptoms, including pelvic pain, bloating, nausea, pain going to the bathroom, and even pain during sex. These symptoms and others can occur at any time during the menstrual cycle. Also, the severity of symptoms don't necessarily correlate with disease severity. True or false? Missing school, work, or social events due to period pain is normal. Not true. Repeatedly missing daily activities due to monthly pain is not normal. If your symptoms interfere with your daily activities, please reach out to a trusted healthcare provider for help. Endometriosis is a condition of 30-year-olds and has no lasting effects. True or false? False. Endometriosis is diagnosed in tweens and teens and throughout the reproductive years. When left untreated, endometriosis can cause tissue damage and reduced fertility in some women. Here's a fun one. Only mammals that menstruate can develop endometriosis. This is true. Only about 4% of all mammals menstruate and potentially develop endometriosis. These include some bats, non-human primates, and humans. The other 96% of mammals do not develop endometriosis. Question: is endometriosis a rare condition? No, endometriosis is quite common. It affects approximately 1 in 10 females, and it is believed that many more have endometriosis, but have not yet been diagnosed. True or false? Diagnosing endometriosis is easy and occurs within months of symptoms. False. Definitive diagnosis requires invasive laparoscopic surgery performed by inserting a camera into the abdomen and collecting lesion biopsies. In some, diagnosis can take up to 7 to 10 years. This is unacceptable and exactly why we started the Rose. The Rose has focused on studying menstrual effluent, or ME, the endometrial lining of the uterus that is shed each month as menses. There are major differences in the endometrium of women with and without endometriosis, and these differences are reflected in menstrual effluent, which can be easily collected at home and studied in the laboratory. Menstrual effluent is an understudied biological sample. Besides our lab, very few scientists around the world have even studied it. We invite you to learn more about the Rose and to join through these links and QR code. We are leveraging menstrual effluent to develop a rapid, non-invasive diagnostic for endometriosis so patients can be treated earlier. And we aren't stopping there. We believe that menstrual effluent provides a window into the uterus and will inform us about other aspects of uterine health, including dysmenorrhea, abnormal uterine bleeding, uterine fibroids, adenomyosis, and even uterine cancer. Thanks so much for joining us today.
Welcome to A Woman's Journey, A Woman's Health Partner. The purpose of this talk is to help you reduce your risks and live a long, healthy, happy life in partnership with your physician. Very important relationship. 3 factors I'd like to start with is reducing your risks. How do you do that? Well, by identifying your specific issues with your physician, you can help protect yourself against future disease and prevent yourself from actually, in many cases, having those diseases. We want to reduce your risk factors and identify those, and we can through behavioral and lifestyle changes and many other aspects I'm going to go into today, reduce your risks and maximize your health and maximize your life. And we're going to talk to you, and your physician is going to talk to you about the signs and symptoms of disease so that you can approach your physician, your trusted health partner, in order to reduce the impact of those diseases. Now, the annual Well Woman visit is very important. Your OBGYN, your obstetrician gynecologist, is in a wonderful position to partner with you to provide complete OBGYN and medical care for women throughout your life, from your first period all the way to the end of your life. This is a relationship. They call it the physician-patient relationship because it is a relationship and it has to be based on mutual trust. We are in a unique position to provide screening, preventative care, and counseling to women, which can have a positive impact on the quality of life, as well as reducing morbidity and mortality. Extremely important. The annual Well Woman visit is where we start. It's a very important place, and it's many, many aspects beyond the Pap test. Some women will say, well, it's just the Pap. Believe me, it is way more than the Pap test. We want you to bring your questions to us, and we want you to come and write them down, because if you're like me, I go to the doctor and sometimes forget what I'm supposed to ask. So write them down, share your questions and concerns with us. We're going to review all of those with you. We're going to take a full medical, personal, and family history, because a lot of the history will help determine what your risk factors and what your potential for diseases. And we want to reduce those, identify and reduce. We're going to do a full physical examination, which most of the time does include a breast and a pelvic exam, although not always. And I'll go into that in a bit. We're going to do some testing, some laboratory testing, blood testing, some cultures possibly, some imaging, and I'll go into that a little bit later. Again, the Well Woman visit is well beyond the Pap test. We're going to talk to you about nutrition and exercise. We want to see what your level of exercise is, your nutrition, your caloric intake. Where do you want to be in terms of your weight? We're going to talk to you about mood to make sure that there isn't depression. And if so, we're going to help you address that. And we're going to get you some assistance with that and always support you in your healthcare goals. We're going to talk to you about any sexual concerns that you might have. Going to talk to you about substances. Are you using substances? Do you have a substance use disorder? It's confidential. Substance use disorder is a disease also, like any disease, like heart disease and diabetes. And we can come up with a treatment plan, a confidential, supportive treatment plan with you. We're going to go over your family history, very important in determining your personal risk. Let's go into detail a little bit more. The gynecologic history, we want to know your sexual history. How many partners have you had in your lifetime? What genders are those partners? And your current partners and their gender. Your contraceptive history. If you've had heterosexual sex, what contraceptives have you used? And what is your current desire in terms of, do you want to become pregnant or not? We're going to talk to you about GYN issues. Have you had fibroids, which have been usually benign growths of the uterus? Have you had ovarian cysts, any infections, any abnormal Pap test? When was your last Pap? Was it normal? What was done? We're going to talk to you about your obstetric history. How many pregnancies have you had? Whether they're vaginal or cesarean section, or whether you did not have a pregnancy that was delivered, if you miscarried, or if you ended a pregnancy. We want to know all of this. Again, confidential. We want to know your medical conditions, personal medical conditions, your family history, your previous surgeries. What medications do you take, both over the counter, natural medications from the health food store, possibly some vitamins, or prescribed medications? We want to know the dosage and how often you take it. And we want to be screening you for what we call IPV, a little bit of a difficult subject to talk about. It's called intimate partner violence, which unfortunately affects 32 million Americans, and up to 40% of women in the United States have been a victim of intimate partner violence. Now, this is defined as abuse or aggression that occurs in a romantic relationship. And it refers to both current and former spouses or even a dating partner. Intimate partner violence can be one, God forbid, devastating situation that happened that has far-reaching effects for a lifetime, or it can be multiple small intimate partner violence issues. And we want to talk to you about that, and we're going to be supportive and empathic. We're going to validate your experience. We're going to give you assistance, and we're going to empower you. But most importantly, we're going to help you make sure that you feel safe and connect you to appropriate resources. So let's talk a little bit about the physical exam after we've taken that long history, that big history, quite extensive. The breast exam is important, and we want to examine your breasts in the context of your annual visit once a year for every woman over 40. We want to do it every 1 to 3 years if you're in the age group 25 to 39. In addition to our breast exam, we want you to know your breasts. We call it breast self-awareness. What that means is you know what your breasts look like in the mirror. You know when you're examining them in the shower, covering the whole breast area. It doesn't matter if you're doing it in an up and down type of fashion, a wedge like a pie or circles. We want to make sure that you know your breasts, and you can examine them in the shower when the breasts are nice and slippery with soap. You're washing them anyway. So go a little deeper and make sure that you don't feel any abnormalities or lumps. And you can look in the mirror, very important, Tell us if you feel a lump, or in the mirror, if you see anything abnormal. Is anything swelling or pulling in? Is there a nipple discharge? Does one breast suddenly look bigger or smaller than the other? Everybody has a little bit of asymmetry or inequality of the breast, but if that's a change, we want to know. We want you to perform this at intervals you're comfortable doing, and we'll examine you every 1 to 3 or every year, depending on your age. And the screening mammogram we recommend age 40 and above every year. The reason we do that is that breast cancer is very common, as we all know, and it is more common with increasing age. And also, most importantly, we may not feel something. It may be not able to be felt because it's so small, and you may have not felt it. We may not feel it because it's so tiny, but a mammogram will pick that up. So we combine our exam with your breast self-awareness with the mammogram. Now, the pelvic exam is the next area I want to cover. We do a pelvic exam because this way we can detect treatable conditions such as infections or cysts or fibroids. It will help you understand your body better, and we can reassure you about your sexual and reproductive health. So we do an external exam of the vulva or the outside of the vagina, looking for any abnormalities. Then we put a speculum in, specific for your vaginal size. Some women have smaller or larger vaginas. We adjust the speculum size. We have many sizes. And we look at the vagina and the cervix, see if there's a discharge or any what we call lesions or abnormalities. We may do your Pap test if it's time with your HPV most of the time, or a large majority of the time. And I'll go into that in a little bit. And we may do cultures if we're screening for sexually transmitted infections. We can take a Q-tip swab and test for gonorrhea and chlamydia, just by way of example. We remove the speculum and we examine the pelvic organs with our hands. We put 1 or 2 fingers, gloved fingers, into the vagina with a lot of lubrication, and we lift the cervix and we press down on the abdomen, and we can tell if there are any abnormalities in your uterus, or the area next to the uterus is called the adnexa. That's the fallopian tubes and the ovaries. So we can tell if there are any masses present there, and if there's any question, we would get a sonogram or imaging to see if in fact there is an abnormality present. And the pelvic exam is very, very important. The Pap test is important because it screens for cervical cancer, and most people do know this. And there's an area that we take the Pap from around the opening of the cervix, which is called the os, O-S, means mouth in Greek. And we take a spatula and a little brush, and we take cells from that area, and we put it in a liquid. Some people put it on a slide, but these days most is liquid. And we check a Pap for abnormal cells from that area or an HPV. We usually do both Pap and HPV. Every 3 years, the Pap, age 21 to 29, age 30 to 65. We do it every 5 years, generally with an HPV. And 65 and older, if you have other risk factors, we may do the Pap, even 65 and older. For example, if you have a new partner, or if your current husband or partner or wife has a new partner, we may go ahead and screen you a little bit more often, because we don't want anybody bringing in extra sexually transmitted infections, most notably HPV, which causes cervical cancer, most common reason for cervical cancer. We want to screen you very carefully. And very quickly, just to mention, the reason that we take a Pap from that area is the vagina is an acid pH, and the cervix gets damaged. Nothing you would notice, but the cervix cells in that area around the mouth of the opening of the uterus, the os, those cells get damaged and they heal. And those healing cells are young cells. They're called metaplastic cells. And those cells are very vulnerable to HPV. So that's where the HPV will basically be attached to and potentially cause cervical cancer or precancer, which is called dysplasia. So now I'd like to talk a little bit about sexually transmitted infections, which are totally preventable if you never have sex. Human beings are sexual beings. So most of us are sexually active in some degree to some form. So dental dams on the vulva will protect most STIs from happening if you're engaged in oral sex with any gender. And condoms, of course. Condoms are not 100% for pregnancy or STIs because you can have transmission from the scrotum to the vulva, for example. So condoms, dental dams, and abstinence. STIs basically are bacteria or viruses or yeast. Syphilis is called a spirochete. Bacteria is basically gonorrhea, chlamydia, treated with antibiotics, also trichomonas, bacterial vaginosis. Yeast are treated with antifungals, and viruses, we don't have a treatment. So it's really important to make sure you're protecting yourself against STIs because there is no treatment for virus. That's the most devastating reason for somebody to come in and say, God forbid, all of a sudden, if they contract hepatitis or HIV. So protect yourself, very important. From 13 to 19, most of this is true for most ages. I'm just going to go through from 13 to the end of life and talk about what's different in each age group. Well, for every age group, we do a full history and physical, as I mentioned. We're going to provide psychosocial guidance to make sure that young woman is not being bullied, for example. We're going to screen for substance use disorder. We're going to talk about smoking cessation, if that's an issue, sexuality education, pregnancy prevention, very important, fitness and nutrition. The lab testing would basically be just a complete blood count or a CBC. And if the woman is sexually active, we're going to be doing STI testing, of course. For women 20 to 39, we're going to add for that mammogram for high-risk groups. If someone in your family, if you have a personal or family history of genetically associated breast cancer, we may begin offering a mammogram or even starting with a breast ultrasound. We're going to talk about fitness, psychosocial screening to make sure there is no IPV, intimate partner violence going on. And if so, as I mentioned, offer support and tools so that you do feel safe in your home and in your environment. Substance use disorder screening, very important. And we're going to start to screen you for incontinence because it can start to increase in this age group, leaking especially with coughing, laughing, and sneezing, or the gotta go, going to the bathroom more than every 2 hours or so could be associated with a little bit of an overactive bladder. We do a Pap and HPV, STI testing as indicated, and a complete blood count. Once you hit 40 to 53, we're going to start screening you a little bit more intensely for cardiovascular risk because it starts to go up in this age group. Your mammogram, of course, every year, your colonoscopy from 45 and above, and the interval of colonoscopy is really based on your personal and family risk. Pregnancy prevention, because the highest risk of unintended pregnancy is in this age group. And we want you, if you're heterosexually active, to not have a pregnancy unless you want to have a pregnancy. It's much easier to prevent than to deal with an unintended pregnancy. And again, incontinence and pelvic organ prolapse. For lab tests, we're going to add for this group a thyroid stimulating hormone, a TSH, because thyroid disease, sluggish thyroids especially, start to increase from the age of 40 and above. And of course, the fasting glucose, because diabetes and prediabetes, if we can prevent prediabetes from increasing to diabetes, we will help you do that. From 53 and beyond, we're going to more intensely screen you for cardiovascular risk, colonoscopy, mammogram, a bone density at age 65 and above to identify any osteoporosis or any osteopenia, which is the step before osteoporosis, and incontinence and pelvic organ prolapse, which affects 3 out of every 5 women from 53 to the end of life. So very important for us to screen, because if we screen and we identify what you have, we can help you and possibly return you to continence so that you do not need any more extensive treatment for incontinence or prolapse. And there are many, many things we can do. Obviously, if you're in a different relationship, STI screening, of course. And pretty much the same lab tests as we mentioned for the previous age group. I wanted to talk a little bit about the incontinence, which is involuntary leakage caused by a variety of factors, mainly weakness in muscle and connective tissue from childbirth, for example, or problem with the nerves, which leads to the overactive bladder. Overactive bladder or urgency incontinence happens when the nerves signal the bladder to contract and you don't have time to get to a bathroom, and then usually the entire bladder contents empties, which is very disconcerting. Many treatments available for this. Most of them are non-surgical, by the way. Stress incontinence is a weakness of the muscle and connective tissue. When somebody coughs, laughs, and sneezes, you may experience a leak of urine, a spurt. That's from weak muscle and connective tissue, generally, again, from childbirth and also loss of estrogen in menopause, gravity, coughing from smoking. If you have a chronic cough, if you're constipated, many reasons for stress incontinence and many treatments available, some surgical, but most non-surgical. Again, a well-placed surgery, if you have severe stress incontinence, can be invaluable, but only if you choose it and only if you have really known what all of your options are. So in conclusion, just to end this chat that we've had, I just want to mention that pelvic organ prolapse is basically a hernia. When the bladder drops, it's called a cystocele. When the uterus drops, we call it uterine prolapse. And when the rectum drops, it's called rectocele. And again, this is from weak muscle and torn connective tissue. So very important to identify this early, so you can do things like Kegel exercises, for example, maintaining a good body weight so it presses less on the organs, presses them down less. And the most common reason, again, for prolapse and stress incontinence, by the way, is childbirth, followed by menopause, coughing, and obesity. And there are many other reasons. So you may experience prolapse as a bulge in the vagina. That's the most common symptom. So again, we want you to bring your questions to us. We want you to feel empowered. We want you to be empowered. We want to help you reach your healthcare goals. So bring us your questions, identify your health goals, and create your own health action plan. It's been a pleasure talking to you today, and I wish you the best of life and the best of health. Thank you so much.
Welcome. My name is Christina Brennan, and today I'm going to talk about women in clinical trials. Historically, women were assumed to be just like men, except for their bikini parts. This led to women actually being excluded in research trials with the concern they would be harder to study due to those pesky hormones and changes women's bodies go through each month during much of their lives. So why not just study men and assume women are the same? Clinical research trials can benefit from attracting a sample population that represents the population as a whole. Women have been historically underrepresented in clinical research. Women's participation in clinical trials is crucial to understanding sex-specific differences in data. These factors include social, economic, health-related, and physiological factors affecting their decision. Many studies have been conducted to show women are an important underrepresented population in clinical research. Historically, this can be attributed to the Food and Drug Administration's 1977 decision to prohibit the participation of fertile and pregnant women in phase 1 clinical trials. In recent years, it has been recognized that women are an essential demographic in clinical trials. In 2014, the National Institute of Health instituted a policy requiring preclinical research to consider sex as an important biological factor. The policy went into effect in January 2016 and requires researchers to justify whether the study focuses on only one sex. To increase women's participation in clinical trials, researchers must understand why women are reluctant to enroll. A study was conducted to assess the socio-demographic, health-related, and psychological factors influencing women's participation in phase 3 clinical trials of low-dose tamoxifen, a drug that's used in individuals with breast cancer or as a prevention option for those at high risk for breast cancer. The researchers concluded increased participation was linked to satisfaction with study personnel, younger age, lower breast cancer worry, and risk perception. Another study was conducted for a systematic review in recent years to identify the reasons for and against participation in studies of medicinal therapies for women with breast cancer. They concluded that younger patients and those who viewed their risk of breast cancer as subjectively higher were more willing to participate in clinical research. Women were discouraged from participating in studies due to fear of possible side effects. There are many factors associated with women's underrepresentation. Some diseases present differently in women compared to their male counterparts, leading to their underdiagnosis, undertreatment, and poor outcomes. Many healthcare providers assume women's symptoms are not sick enough to participate in a clinical trial. In 2018, a study published found that fewer women go through screenings for trials, indicating women are made less aware of resources and opportunities for their participation, inhibiting access to these trials. Even with adequate representation in clinical research, there is a lack of data that is being analyzed to generate appropriate gender-based outcomes, which would aid in uncovering new understandings of the potential risks and benefits of treatment. It is critical to involve women as early as possible in the clinical trials to learn about how medications and treatments work in their bodies and to ensure they are safe and effective in the female population. Not only do women need to be recruited and enabled to complete trials, but data must be evaluated and presented by sex. Sex as a biological variable. Sex always has to be considered as a variable and data needs to be separated by sex. So understanding the factors impeding female clinical trial recruitment and participation will help researchers adapt to new recruitment strategies to encourage more women to participate in clinical trials. The knowledge will help institutions nationally recognize why women are hesitant to enroll in clinical research studies. Researchers should facilitate setting up environments that allow women to easily access the facilities, such as transportation, compensation, and accommodating their needs. This will allow for more robust participation and hence uniform data applicable across all gender lines. Thank you.
About a year and a half ago, I was planning a volunteer trip. There were 12 of us going to help assist with the refugees in Greece.
I was actually in boot camp, putting this fake helicopter fire out, and all of a sudden, I just remember everything going black.
I felt like I needed oxygen so badly. I was short of breath, and I felt really sick.
They just said, oh, you're dehydrated, you're exhausted.
Breathe it out. Maybe it's just anxiety.
They never told me to go get checked by a cardiologist.
Relax, because I was feeling anxiety. And I was like, okay, I mean, you're the doctor.
Women have higher mortality rates than men when they have a heart attack. Women are less likely to be treated with evidence-based therapies when having a heart attack. My name is Allison McGregor. I'm an attending physician at Rhode Island Hospital, and I'm the director for the Division of Sex and Gender in Emergency Medicine. How is Miss Bright?
She's over in the chest pain unit.
Chest pain unit, okay. I will go check in on her. If a woman presents to the emergency department having a heart attack, there is great potential that that will not be recognized. Hi, I'm Dr. McGregor. So what happened tonight?
I ain't never been so scared in my life like this.
Okay.
I don't feel good. Something's wrong.
In general, men who are having a heart attack present with crushing chest pain. Women, however, don't often call it pain. They're more likely to describe it as an uncomfortable feeling. I'm just going to listen to your heart here. Most of our diagnostic testing has been developed to detect the way that men have disease. Okay. And do you have that chest discomfort right now while we're sitting here? We don't fully understand how this disease manifests in women, how to diagnose it, and then how to adequately treat it.
In the United States, there's a big health disparity between men and women in terms of the care that they receive. We're really at the point now where we're just beginning to investigate and understand why that is.
If we now know that women may have a different way of having cardiovascular disease, what about stroke? And what about infections? And what about cancer? And what about trauma?
Our society doesn't value women, and so, and that's a broad statement, but what is really important for women is advocating for themselves, because unfortunately, no one else is doing the advocating for them or us.
I would hope that this film would inspire other people to see that not only is it important, not only is it social injustice, but that we can do this. We can do it.
Good afternoon, and thank you for joining us. I am Dr. Jennifer Merez, Professor of Cardiology and Associate Dean of Faculty Affairs at the Zucker School of Medicine and a Senior Vice President and Chief Diversity and Inclusion Officer at Northwell Health. I'm excited to be moderating this conversation about gender inequity in healthcare. The topic is timely, as just 2 weeks ago, in the May 2021 issue of the scientific journal The Lancet, published findings of the first ever cardiovascular disease commission for women. And this commission, led by 17 leading experts from 11 countries, the authors outline 10 ambitious recommendations to take inequities in diagnosis, treatment, and prevention to reduce cardiovascular disease, including educating healthcare providers and patients on early detection to prevent heart disease in women. Yet, after almost 20 years of grassroots programs focusing on increasing awareness and scientific evidence about heart disease in women and outlining the sex and gender differences, cardiovascular disease remains the leading killer of women in the United States and in the world. The Commission issues a call to action to reduce the global burden of cardiovascular disease in women by 2030. And so the Commission, the first of its kind, is issuing this worldwide call to all of us in the medical community, as well as in the private community, that we need to empower women to be partners in their health and to know that cardiovascular disease, heart disease, is their #1 cause of death. So with that in mind, we are fortunate today to be joined by Trisha Reagan, director, producer, and cinematographer of the documentary Misdiagnosed. Trisha is an Emmy Award-winning filmmaker working in both feature documentaries and nonfiction television. She's the winner of a Primetime Emmy for Best Documentary for the HBO film Autism, the Musical, and her work has been premiered at the Sundance and Tribeca Film Festivals. Joining Trisha, we're fortunate to have with us a luminary in the area of cardiovascular disease in women, Dr. Sharon Hayes, cardiologist and professor of cardiovascular medicine, as well as founder of the Women's Heart Clinic at the Mayo Clinic in Rochester, Minnesota. Dr. Hayes has focused her clinical research on sex and gender-based cardiology and caring for a wide variety of cardiovascular conditions that occur primarily and or differently in women, spanning prevention, diagnosis, and treatments across the lifespan. And Dr. Hayes is featured in the movie Misdiagnosed and is also a dear friend. I would also like to thank my co-executive producers, Dr. Stacy Rosen and Lori Russo. Without their commitment and support, this project would not have come to fruition. Truly, it was a labor of love to get Misdiagnosed, to be premiered just before COVID happened. So let us start the conversation. So Dr. Hayes, historically, medicine has been defined by the male model. Research protocols have focused exclusively on male, animal, and human cells. The assumptions were that whatever worked in men would work in women. And over the past 2.5 decades, you and several researchers have proved that theory wrong. Tell us a little bit about where we are in terms of understanding the sex and gender differences with cardiovascular disease in women.
Well, I will start by saying there have been some huge successes and we know a whole lot more, but still not enough. To quote our colleague, Dr. Nisa Goldberg, women are not small men. But what we didn't acknowledge back then, and we know now, based on the Institute of Medicine, is every cell has a sex. Think about that. Every tissue, every organ in the body of a woman is different than every tissue and organ in the body of a man. The fact that women compared to men may manifest health and disease in different ways, respond differently to treatments, or have different values and priorities in their personal lives should come as no surprise. But that is not something we were acknowledging 20, 30 years ago. So going back in time to when I first started practicing, I found that in my clinical practice in the 90s, I would sit down with one of my male patients and their responses to medication, the results of diagnostic tests I ordered, and the research evidence that I had to provide advice to them with was generally as expected and fairly robust. But for my women patients, I either had no data whatsoever, or when I applied the data that had been created based on research on men, the outcomes were not necessarily what I expected or predicted or like the men. So we came from a place of relative ignorance because women had been actively excluded from heart-related research. And even when they were included, the data were lumped together. So you didn't know whether there were any differences between men and women. It could not be discerned. So the lack of inclusion of women in research, which now in retrospect seems so incredibly misguided and paternalistic, set the stage for really many incorrect assumptions, both missed and delayed diagnoses, and over and under treatment. By not including premenopausal women in research because they were too complicated due to their hormones or to protect them because they might get pregnant, we lost a huge opportunity to better understand heart disease in younger women. And then by excluding all patients over the age of 65, which most of the early trials did, that had the inadvertent effect of excluding women who tend to get heart disease a decade later. So you included more men than women. So it was a default. So we're still playing catch up in understanding heart disease in women in general, but particularly in the elderly and in reproductive age women. But to get back to your question, what do we know now? First, from a purely scientific standpoint, we know that we cannot exclude women or ethnic minorities or the elderly or other groups from important research about conditions that affect them. We need to get better at designing the original research to be inclusive of all the individuals who are affected by those conditions. And in many cases, that means that our research should include more than 50% women. And that's virtually unheard of in cardiovascular disease. So we've also learned that from everything from hypertension to heart failure to stress testing to chest pain or transplantation, not only will women benefit from different diagnostic testing or treatments, but in the past 3 decades, there are several entirely new conditions that we did not have a name for when I came into practice, that we know predominantly affect women and that we are still learning. So one example is microvascular coronary disease. It's predominantly a female condition and a major cause of chest pain and reduced quality of life. 20 plus years ago, and I know it's in your career too, after having an abnormal stress test, they then go to an angiogram. The angiogram would be normal, and the women would be told, you had a false positive test, you don't have heart disease, and they were dismissed to their OBGYN, right? They were actually sort of implied that this chest pain was in their head. We now know, based on research and studies that were led by our colleague, Dr. Noel Berry-Mers and Carl Papine, that there is this microvasculature that's really important for women, and these women had real angina that can be treated. Another is how women respond differently to high blood pressure. Their hearts actually respond differently. So they are more likely to get heart failure, but the pumping function is still normal. So heart failure with preserved ejection fraction. We did not have a name for that 20 years ago. We didn't have a treatment. And in fact, we implied that all of those women were just fat, out of shape, and that's why they were short of breath. So they were basically told, you're getting old and deal with it. The reason that we weren't testing the women. And so we, to this day, don't have a single treatment targeted at this condition. So I think that we have learned so much. We have new conditions to research and treat, but we're still playing catch up.
So no question, women are being understudied, undertreated, misdiagnosed. And you're absolutely right. We have a long way to go. Part of what is important about heart disease is truly, 80% of heart disease can be presented by early diagnosis, knowing the symptoms. And women very often show up in the emergency room way too late to get life-saving strategies. So we embarked on this project of storytelling as a powerful way to convey to all of our women in the world, well, it's starting in the United States, heart disease is the #1 killer, but you've got to be educated and you've got to put yourself first on the list and take care of your heart. So the project of doing Misdiagnosed, which comes 20 years after we embarked on the sex and gender aspects of research, is so timely. So Trisha, tell us a little bit about what you discovered in traveling the country, speaking to women across the United States. What have you learned, and what were they telling you? And how did what was important about making this film Misdiagnosed to you?
Sure. You know, this issue of women not being paid proper attention to in medicine, the paternalism, it's not occurring in a vacuum. It's occurring in a community and in a world where women are undervalued. And what we're learning in these last couple of years, we're all waking up to the fact that when you are in a class of people that is undervalued, you tend to undervalue yourself, and that has all sorts of implications. So, you know, the women that there's, you know, a lot of women in this film, and, you know, the ongoing story was, well, you know, I had symptoms, I went to the doctor, they told me I was okay. And it was always a male doctor, and they'd go home and they would get sicker. And then another woman in their lives would generally intervene, generally a mother or a female nurse in one case. And in one case, the woman had just had a baby and her in-laws were in town, and she went back to the emergency room a second time in a weekend. And a nurse said, look, I know you would not be back here with 2 babies at home and your family in town unless this was something really serious. So we're going to take another look. I'm going to make sure that happens. And that saved her life. So I think, you know, in the making of this film, more than just the information, which a lot of women don't have access to, it's also trying to encourage women to be a part of the solution in their own lives and in the lives of other women that they know, you know, through politics, through, you know, sharing of information, through being your own advocate through the medical system. You know, because we are more than 50% of the population as women. So we have to take responsibility for the sea that we are living in if we want to see change. So that, you know, I think all of us wanted this film to leave women feeling empowered and like they play a vital role in their own health. And I think that the film does that. So, and, you know, Dr. Hayes was our hero. Literally, we always laugh. There's one scene where she's marching across the Mayo Clinic lobby and we have this music playing and it's like, here she comes. You know, she's the superwoman who's going to save the day. So, you know, making a film is an incredible journey, as you know, Jennifer, and a great opportunity to meet women all over this country. And I have learned for myself to advocate through the medical system by doing this film. So,
well, I think, thank you. We've learned that, you know, healthcare is really a team sport, right? And we all patients one day. We have got to be part of the healthcare team, right? And really be a partner in this journey to health and wellness. So I'm going to turn back to Dr. Hayes to find out a little bit about where have we come as a nation in terms of looking at women and heart disease. And I want to specifically focus on Women Heart. Women Heart, the National Coalition for Women Living with Heart Disease, was founded by 3 women who were misdiagnosed. Dr. Hayes and the Mayo Clinic have shared the honor and distinction of working with women across the country. Many of the women were featured in the film to truly educate and empower women to be ambassadors, to go back to their communities and talk about heart disease. So Dr. Hayes, tell me a little bit, give us a little bit about, you know, what that experience has been like, and are we moving the needle in empowering women to be partners in their health and in the fight against heart disease?
Yeah, thanks for that. So I think that the rise of the patient advocate, the majority of whom are women, along with leveraging social media and networks to advance policy, to educate, by Women Heart, the National Coalition for Women with Heart Disease, is really emblematic of some of the things that have to be done and that have been particularly effective in heart disease in women in raising awareness, generally, not just among other women, but actually raising awareness to leaders of this country. And I think that the partnership between a nonprofit, patient run organization and healthcare, cardiologists in general, so organized medicine, has the potential to make change where individual patients and individual doctors do not. And I think that's one of the powers. I think the other is empowering those individual women heart champions. So for those of you, a little more definition, women heart champions, that designation is not just any woman with heart disease. It is a woman who has decided that they're going to volunteer their time to not only learn content, but also to commit after they learn that content about heart disease, about supporting other women, about advocacy, and then actually committing to forming a support network of other women, of going out and educating other women. Very grassroots, has been called the stilettos on the ground. And it is a model that other disease states have actually looked to replicate, because not only are the individual women heart champions empowered and educated, they also have the potential of reaching other women in a way that Dr. Merez and I do not, right? Because we wear the doctor hat, and hearing about patient stories, as you have seen and or will be able to see in Misdiagnosed, is one way of changing hearts and minds. And the hearts and minds can be changed in everything from, you know what, I think I'm going to get that symptom checked out myself. You know what, I'm going to urge my spouse, my daughter, my mother, or my husband, perhaps, to get their symptoms checked out. To, you know what, it is unfair, that policy, that it doesn't cover cardiac rehabilitation for women. I'm going to advocate that we get better coverage for something that saves women's lives. And all of those are real examples of things that have come out of this patient advocacy. And often because people hear about a big problem like heart disease in women much differently when it comes from the mouth of a woman who has experienced it. And so I do think that that is one way. I will caution us, though, that the health of women's hearts should not fall on the women who have heart disease, right? And that's where I think, to a certain extent, they need to lift up the problem to those of us and others who can help solve it. And that's a bigger societal issue.
No, thank you for that. I mean, we are all, rowing in the same direction, and it has to become a we problem, a societal problem. So Trisha, truly, definitely award-winning film, Misdiagnosed. We premiered at CineQuest. Give us a little bit of some of the highlights for you as you met some of the women that we featured. What were some aha moments, from Kelsey to Brandy to Catherine? What would you want our audience to know about some of the experiences that you shared firsthand?
Well, first, it's kind of remarkable that this film has won 3 awards in a pandemic year, where, literally at our premiere at CineQuest in San Jose, that is when the world shut down. We didn't even get to screen it all 4 times. We were there, Sharon was there, you couldn't go, like you weren't allowed to travel, and it was a ghost town. And so there weren't huge crowds, but the people who came to see it, they did not leave their seats. They stayed for a Q&A. And then when we were forced out of the theater, they cornered us in the hallways. They wouldn't let us leave. Like literally. And I mean, we're inching out the door and they're following us. people can't really believe the state of healthcare. They can't really believe that medicine is so built around the male body. It's shocking to them, and it's shocking to them the ramifications that means for their own health. So, you know, in my journeys of meeting these women, the way that I found them was through Women Heart. I wanted women who had been misdiagnosed and had overcome it and were on some kind of heroic journey of their own, no matter how small. For Kelsey, who was only 32, her heroic journey was like going to college because she had been in the Navy. You know, for Brandy, it was just who needed a heart transplant because of like massive mismanagement of her disease. For her, it was just raising her son to be an adult. That's all she was praying for. Of course, she then, you know, she's a Native American and she was elected chief of her whole tribe, but that's just something she was doing on the side. You know, what I found is that, you know, the kind of trauma that you go through with heart disease, like any other trauma, it's either going to kill you or you're going to overcome it, and it's going to make you stronger because you're going to have a clearer understanding of what's important. And I would say that that is true of every woman in the film. And yeah, my life is forever changed for having known all of them. And I think that the thing about this film is it stays with you, and that's what you want. You want a film where people are literally shifted in their perspective, and that is how change happens. So that's what I feel the most gratitude about in all of our hard work, is that once it really gets out there, it's gonna be part of that sea change.
Thank you. You know, I always say your health is your most important asset. And we as women need to treat our heart health as the most important thing and put ourselves on our list, right? And we know that there are several things we can do to prevent heart disease. Knowledge is power. So Dr. Hayes, give us, you know, if you had to say 4 or 5 things we as women need to do to live a healthy life and to avoid or prevent heart disease, what are those?
All right, I'm going to probably be kind of conventional, but I'm going to be data driven. So if you are a smoker, stop. That is probably the most important thing that that you can do. I saw a patient this morning who came in after 7 months of fatigue with her STEMI, so a big heart attack, and she got revascularized and said, I had no idea that that's 7 months of fatigue, because in the hospital after revascularization, and she was a heavy smoker, she has quit. So that would be the first thing. The second is to move more. And the reason I say exercise, and I don't let that is a 4-letter word, but physical activity is so important, is because of the other benefits. So we know that physical activity improves and reduces the risk of cardiovascular disease. It also improves mood, and women have twice the rates of depression as men do. It improves bone health, it improves balance and strength as we age. So no matter what you're doing more of that. It is also the one behavior change that I can tell you will feel better with. Eating less pie will not make you feel better. So I think that moving more, and so those are my top 2. I think the when we start going down is knowing your numbers, so knowing your blood pressure, and for women, knowing blood pressure is even more important than knowing your cholesterol, honestly, because blood pressure for women creeps up on them and can cause many more of the cardiovascular issues disproportionate to men. I think then taking other steps that will help your well-being, because again, your mental health and well-being, which has been a very challenging thing for women over this pandemic, is one of those things that reaps many benefits, not just for you, but for families and community. And then I would say that if, and again, this isn't personal health, I'm getting a little broader, but women taking steps to help others in their community, and community is broadly defined. This can be by talking about how they solved a problem of finding time to exercise. to talk about maybe it's a recipe for healthy cooking that they think a friend could make for their family. So it is sharing what you have learned, which benefits the giver. And also, women often do not realize that people in the community look to them, and certain communities more than others. And so if women are taking healthy steps, their spouses, their children kind of naturally, or because they can't do anything else, start having a healthier lifestyle as well. So once women do learn about these healthy behaviors, is to share them.
Awesome. You know, healthy women, healthy families, healthy people in their life. So I'm turning back to Trisha as we come to a wrap. How would you like to see misdiagnosed used? You know, what is your wish list and dream list for misdiagnosed? Again, you highlighted the fact we premiered in a pandemic, ever relevant now, the information to empower women, especially when we look at that Lancet publication, you know, the sort of epidemic of the underdiagnosed, undertreated, misdiagnosed. What do you think, what is your dream wish or your list of dreams for misdiagnosed?
Well, you know, again, like, we don't exist in a vacuum. We live in a world that doesn't care about women's health. So we've had a hard time getting the attention of a Netflix or an HBO. And it's the first time that that has happened to me or my editor. So it's not the film. But I think that, you know, aside from, you know, a big airing such as that or broadcast, to get it to medical schools, to get it to nursing schools, to get it to EMT trainings, to get it to women's groups, to get it to community groups, you know, basically to have a push behind it for a big social impact campaign. And I think it's pretty easy with this film because it's entertaining. You know, people sit down and watch it, they watch it all the way through. It's not like taking medicine. And it really, there's no feeling quite like having your perspective shifted. And I think that that's a novel experience. So yeah, my dream would be to get this in front of women and men. We find women are much more open to watching it than men are. Again, it's because we are living in a sea that has a hard time thinking about women and their health. And, you know, very crassly from, you know, my point of view as a professional in the film industry, if it were a film about women being abused, it would get much more attention. So that's something we really need to think about as individuals. Like, in what ways does the world become interested in me? What am I doing when the world is interested in me? And how can I shift that in the way that I'm interested in other women? You know, are my eyes going to glass over when a woman starts talking to me about health, as opposed to, you know, what happened to her with Harvey Weinstein, you know? So that's my wish list.
All right, great educational content, powerful stories, and we're hoping that in the next few months that we find a distributor and a way to get it to medical schools and to large audiences.
Yes.
Women's health continues to be one of the most critical health issues of our time. We want women to see their health as their most important asset. So I want my heartfelt thanks to our panelists, Dr. Sharon Hayes, documentarian Trisha Reagan, for joining me in this important conversation, and a special thank you to everyone in attendance. As we continue our journey toward health equity, gender equity, gaining insights into the diagnosis and treatment of women to achieve better health outcomes, we are changing the approach to healthcare for all women in our communities. So get a friend, get a family member to join you on the journey to heart healthy living. Remember, you know, as per the American Heart Association, 80% of heart disease can be prevented. Knowledge is power, and that's what we tried to show and what we successfully showed with Misdiagnosed. Advocating for ourselves, knowing our numbers, and being an active participant in the whole medical team discussion. Thank you.
Northwell Health is honored and grateful to welcome the Women Who Dared Art Collection, the largest private collection of works created exclusively by women. A selection of works is now on view at Northwell hospitals. The collection includes over 400 pieces, spanning 2,500 years. They are drawn from a wide range of races, ethnicities, and cultures on all 7 continents. From portraits to landscapes and still lifes to abstracts. To bring the works to as wide an audience as possible, we have also created a series of unique, themed wallpapers to display at any number of our hospitals. And QR codes enable viewers to hear the artist's remarkable personal stories, narrated by celebrities and some of the inspiring women of Northwell, who make up over 70% of our staff. What unites the creators of these diverse works and prompted the name for the collection, Women Who Dared, is their boundless desire to produce art. They persevered despite social, political, or economic obstacles, in the face of opposition and even illness. With their art on the walls of our hospitals, the women's unbreakable spirit now serves to heal and inspire the millions of healthcare workers, patients, and their families who are part of the Northwell community. We are thankful to our generous donors who have helped us thus far. Please consider adding your support to help make the rest of this collection available to the Northwell community.
What an incredible way to wrap up an amazing week. Thank you so much to the 92Y team and to Nancy and Larry Roth for making this week possible. And thank you to all our experts for helping to educate us, sharing what we need to know to live our healthiest lives. We know that women are the chief medical officer of their families. They're making the majority of healthcare decisions, which means that healthy, well-informed women lead to healthy, well-informed families and communities. I'm excited to share that we're extending a membership to the CATS Women's Circles for all those who joined us this week. This community of women health advocates and champions are a key part of our mission to empower and educate ourselves and the women in our lives about women's health and caring for our families. At the CATS Institute for Women's Health, we are delivering an innovative approach to women's health care, focused on the unique needs of all women throughout their lifespan. We know that when we raise the health of women, we raise everyone. Thank you for joining us.